Welcome back. Fluid and electrolyte questions are among the most challenging on the NCLEX, not just because they test your knowledge of lab values, but because they require quick critical thinking and prioritization under pressure. In this session, we dive into 50 of the trickiest, most brain-stretching questions you'll ever see on this topic. Expect scenario-based questions, prioritization challenges, SATA, and calculations, everything that mirrors the real NCLEX exam. These questions are designed to make you think like a nurse, not just a test taker. So grab your pen, focus your mind, and let's master fluids and electrolytes together, once and for all. Question 1. A client with severe vomiting for 48 hours has serum sodium of 128 milliequivalent/L. Which order should the nurse anticipate? A. 3% NaCl4 infusion. B. Restrict oral fluids. C. Administer hypotonic 4 fluids. D. Administer isotonic 4 fluids. Answer: D. Administer isotonic 4 fluids. Rationale: severe vomiting causes hypovolemia and hyponatremia. Isotonic fluids, 0.9% NS, are first line to restore volume and sodium gradually. Strategy: remember, acute hypovolemic hyponatremia equals isotonic fluids first, hypertonic only if severe neurosymptoms, seizures. Question 2. Which finding is most concerning in a patient receiving 4-potassium chloride infusion? A. Mild nausea. B. Burning sensation at 4 site. C. Serum K plus equals 5.2 milliequivalent/L. D. Flat T waves on ECG. Answer: C. Serum K plus equals 5.2 milliequivalent/L. Rationale: normal range is 3.5 to 5.0. Potassium greater than 5.0 indicates risk of hyperkalemia and potential arrhythmias. Stop infusion and notify provider. Strategy: safety first. When giving potassium, always monitor serum levels plus ECG changes closely. Question 3. A nurse is caring for a patient with hypercalcemia. Which intervention takes priority? A. Encourage weight-bearing activity. B. Monitor for positive Chvostek sign. C. Restrict oral fluids. D. Prepare for calcium gluconate infusion. Answer: A. Encourage weight-bearing activity. Rationale: hypercalcemia leads to bone resorption and weakness. Weight-bearing activity helps reduce serum calcium by pushing Ca into bone. Strategy: think of what lowers calcium safely, movement plus fluids first, meds last. Question 4, SATA. Which symptoms indicate hypernatremia? A. Dry mucous membranes. B. Bounding pulse. C. Confusion. D. Abdominal cramps. E. Polyuria. Answer: A, C, E. Rationale: hypernatremia causes dehydration, dry mucosa, neurochanges, confusion, and polyuria, if DI present. Bounding pulse is more common in hypervolemia. Abdominal cramps suggest hypocalcemia. Strategy: match sodium status with volume status, hypernatremia equals dry brain. Question 5. A patient with CHF is on furosemide. Which lab result requires immediate follow-up? A. Sodium 140 milliequivalent/L. B. Potassium 2.8 milliequivalent/L. C. BUN 15 mg per deciliter. D. Calcium 9.2 mg per deciliter. Answer: B. Potassium 2.8 milliequivalent/L. Rationale: severe hypokalemia increases risk of life-threatening dysrhythmias, especially on diuretics. Strategy: less than 3.0 K plus equals treat first. Always monitor loop diuretic patients for K plus loss. Question 6. Which fluid is best for a patient with hypovolemic shock? A. 0.45% NS. B. D5W. C. 0.9% NS. D. 3% NS. Answer: C. 0.9% NS. Rationale: isotonic solutions rapidly expand intravascular volume. Hypotonic and dextrose solutions worsen cellular swelling. Strategy: in shock, stay in the vessel, choose isotonic. Question 7. A client has a serum magnesium of 1 mg per deciliter. Which complication is the priority to monitor? A. Muscle weakness. B. Constipation. C. Seizures. D. Bradycardia. Answer: C. Seizures. Rationale: hypomagnesemia increases neuromuscular excitability, tetany, seizures, ventricular arrhythmias. Strategy: think magnesium calms. Low Mg equals hyperactive neurosystem. Question 8, fill in the blank. A nurse is preparing to administer 40 ml equivalent of KCl diluted in 500 ml NS over 4 hours. What is the infusion rate in ml/hr? Answer: 125 ml per hour. Rationale: 500 divided by 4 is equal to 125 ml/hr. Strategy: calculation questions are easy points. Always double-check safe infusion rate, less than 10 ml equivalent/hr peripheral line. Question 9. A patient has a serum phosphorus level of 2.0 mg per deciliter. Which food should the nurse recommend? A. White rice. B. Chicken breast. C. Lettuce. D. Apple juice. Answer: B. Chicken breast. Rationale: meat, dairy, nuts, beans are high in phosphorus. Needed for bone and energy metabolism. Strategy: for hypophosphatemia, think protein and dairy. Question 10. During 4-calcium gluconate infusion, which finding requires the nurse to stop the infusion? A. HR 98 BPM. B. Patient reports metallic taste. C. BP drops from 120/80/90/50ths. D. Slight flushing. Answer: C. BP drops from 120/80/90/50ths. Rationale: rapid infusion causes hypotension and cardiac arrest risk. Stop infusion, notify HCP. Strategy: always monitor BP plus cardiac rhythm during calcium-4 infusion. Question 11, SATA. Which of the following can cause pseudohyponatremia, measured low Na despite normal serum osmolality? A. Hyperglycemia. B. Hyperlipidemia. C. Hyperproteinemia, e.g., multiple myeloma. D. SIAD. E. Mannitol infusion. Answer: B, C. Rationale: pseudohyponatremia is lab artifact from very high lipids or proteins altering plasma water fraction. Hyperglycemia causes true, translocational, hyponatremia. SIAD is true hyponatremia. Mannitol usually increases osmolality hypernatremia risk. Strategy: distinguish lab artifact, lipids/proteins, versus osmotic shifts, glucose, mannitol. Question 12. A client with DKA has serum potassium 4.6 ml equivalent/L before insulin therapy. What is the nurse's priority? A. Administer potassium immediately. B. Hold potassium and begin insulin. C. Begin insulin and monitor K+ closely, supplement as needed. D. Restrict potassium intake. Answer: C. Begin insulin and monitor K+ closely, supplement as needed. Rationale: insulin will shift K+ intracellularly and can precipitate hypokalemia. Unless K+ is already high, greater than 5.5, you still start insulin but monitor and replace when it drops. Strategy: in DKA, K+ may be normal/high despite total body depletion, expect drop after insulin. Question 13, calculation. A patient's measured total serum calcium is 7.6 mg per deciliter. Serum albumin equals 2.0 g/dl. What is the corrected calcium? Use correction. Corrected Ca equals measured Ca plus 0.8 times, 4.0 minus albumin. Show the final value in mg/dl. Answer: 9.6 mg per deciliter. Rationale/calculation. Difference equals 4.0 minus 2.0 is equal to 2.0. Correction is equal to 0.8 times 2.0 equals 1.6. Corrected Ca equals 7.6 plus 1.6 is equal to 9.2. Wait, recheck math. 7.6 plus 1.6 is equal to 9.2 mg/dl. Corrected final answer, 9.2 mg per deciliter. Strategy, always correct Ca for albumin. Low albumin makes total Ca appear low. Ionized calcium may be normal. Note, I corrected the arithmetic in line. 7.6 plus 1.6 is equal to 9.2. Question 14. Which fluid is least appropriate for a patient with increased intracranial pressure, ICP? A. 0.9% NaCl. B. Lactated ringers. C. D5W. D. Hypertonic saline, 3%. Answer, C. D5W. Rationale, D5W is effectively hypotonic once dextrose metabolized, can increase cerebral edema. Isotonic or hypertonic saline are used based on volume/osmolar needs. Strategy, for ICP avoid hypotonic fluids that worsen cerebral swelling. Question 15, prioritization. Which client should the nurse assess first? A post-op patient with urine output 20 ml per hour times 2 hours after receiving 40 ml equivalent KCl4 in 500 ml NS. B. Patient receiving 0.45% NS with serum Na 130 ml equivalent/L reporting headache. C. Patient on furosemide with serum K plus 3.2 ml equivalent/L complaining of muscle cramps. D. Patient on TPN with new onset hyperglycemia. Answer, A. Post-op patient with urine output 20 ml per hour times 2 hours after receiving 40 ml equivalent KCl4. Rationale, low urine output plus recent KCl infusion risks hyperkalemia/oliguria. Immediate priority to prevent life-threatening hyperkalemia. Strategy, consider interventions that could cause immediate life-threatening complications, electrolytes plus poor renal output. Question 16, SATA. Which mechanisms shift potassium into cells? A. Insulin. B. Beta-2 agonists, e.g., albuterol. C. Acidosis. D. Alkalosis. E. Cell lysis, tumor lysis. Answer, A, B, D. Rationale, insulin, beta agonists, and alkalosis shift K plus into cells. Acidosis and cell lysis shift K plus out of cells. Strategy, memorize, inwards equals insulin, beta agonists, alkalosis. Outwards equals acidosis, cell breakdown. Question 17. A patient with chronic hyponatremia, Na 122 ml equivalent/L stable for weeks, develops seizures. Which action is most appropriate? A. Rapid correction with 3% NaCl to normal levels immediately. B. Slow correction with oral salt tablets only. C. Careful, controlled use of hypertonic saline to raise Na by less than or equal to 4 to 6 ml equivalent/L in first hour, monitor closely. D. Fluid restriction only. Answer, C. Controlled hypertonic saline to raise Na modestly and monitor closely. Rationale, chronic hyponatremia corrected too quickly risks osmotic demyelination. However, severe neurosymptoms, seizures, warrant limited rapid correction with hypertonic saline to a small safe increment, with close monitoring. Strategy, balance neurologic emergency versus risk of rapid correction. Small, targeted increases. Question 18, odd one out. Which finding is least consistent with SIADH? A. Euvolemic hyponatremia. B. Low serum osmolality. C. High urine osmolality. D. High serum uric acid. Answer, D. High serum uric acid. Rationale, SIAD typically causes low serum uric acid due to dilution and renal handling. The others are classic SIAD features. Strategy, recall SIADH equals low serum osm, concentrated urine, euvolemia, uric acid tends to be low. Question 19, calculation. You need to replace a 2L fluid deficit using 0.9% NS. How many ml of NS will you administer? Assume deficit replacement equals full volume. Answer, 2000 milliliters 2000 milliliters. Rationale, 2L equals 2000 milliliters. If replacement calls for full deficit, give that volume as ordered. Strategy, convert liters milliliters, 1L equals 1000 milliliters. Question 20. A patient with hyperkalemia, K plus 6.5 milliequivalent/L, is unstable with peaked T waves and hypotension. Which is the immediate nursing action? A. Administer oral K-exolate. B. Give 4 calcium gluconate, then insulin plus D50, and prepare for possible dialysis. C. Begin loop diuretic only. D. Give 4 potassium chloride. Answer: B. Give 4 calcium gluconate, then insulin plus D50, and prepare for possible dialysis. Rationale: calcium stabilizes cardiac membranes immediately, insulin plus glucose shifts K plus intracellularly, dialysis removes K plus if refractory. K-exolate is slower. Strategy: in unstable hyper-K, calcium first, then measures to shift/remove K. Question 21, SATA. Which conditions commonly cause hypomagnesemia? A. Chronic alcoholism. B. Proton pump inhibitor, PPI, use. C. NSAID use. D. Diarrhea. E. Hyperparathyroidism. Answer: A, B, D. Rationale: alcoholism, PPIs, long-term, and GI losses, diarrhea, cause low Mg. NSAIDs less commonly cause Mg loss. Hyperparathyroidism usually increases Mg excretion but is not a common direct cause. Strategy: think GI losses and poor intake/absorption for low magnesium. Question 22. Which acid-base disturbance shifts potassium out of cells, raising serum K+? A. Metabolic alkalosis. B. Respiratory alkalosis. C. Metabolic acidosis, high organic acids. D. Respiratory acidosis. Answer: C. Metabolic acidosis, especially organic acid accumulation. Rationale: in acidosis, H+ moves into cells and K+ moves out to maintain electroneutrality. Organic acids have a stronger effect. Strategy: acidosis often hyperkalemia, watch for ECG. Question 23, case. A 70 years old with CKD stage 4 has serum phosphate 6.8 mg per deciliter and calcium 8.8 mg per deciliter. Which intervention is most appropriate? A. Oral phosphate binders with meals. B. For calcium gluconate infusion. C. Encourage dairy intake. D. For insulin plus D50. Answer: A. Oral phosphate binders with meals. Rationale: hyperphosphatemia in CKD managed with phosphate binders to reduce GI absorption. For calcium could cause calcification, dairy increases phosphate, insulin doesn't lower phosphate acutely. Strategy: in CKD hyperphosphatemia binders plus dietary restriction. If you're enjoying this video so far, like and subscribe. Question 24, fill in the blank. A patient on chronic loop diuretic therapy develops metabolic alkalosis. The nurse knows this is often accompanied by electrolyte abnormality that perpetuates alkalosis. Answer: hypokalemia. Rationale: loss of K+ and H+ with loop diuretics causes and maintains metabolic alkalosis. Strategy: link diuretics K+/H+ loss metabolic alkalosis. Question 25. Which electrolyte abnormality classically produces prolonged QT interval and risk of torsades? A. Hyperkalemia. B. Hypomagnesemia. C. Hypercalcemia. D. Hypernatremia. Answer: B. Hypomagnesemia. Rationale: low Mg predisposes to prolonged QT and torsades de points. Hypokalemia also can prolong QT, but among options Mg is classic. Strategy: hypo-Mg, think arrhythmias and torsades. Question 26, SATA. Which clinical features suggest hypocalcemia? A. Positive Chvostek sign. B. Muscle cramps and tetany. C. Shortened QT interval. D. Prolonged QT interval. E. Bradycardia. Answer: A, B, D. Rationale: hypocalcemia, neuromuscular irritability, Chvostek, cramps, prolonged QT, shortened QT occurs with hypercalcemia. Strategy: hypoCA equals tetany plus prolonged QT. Question 27, calculation. A patient is ordered KCl 20 ml equivalent to be added to 4 fluid. You have vials of concentrated KCl 2 ml equivalent /ml. How many ml do you draw up? Answer, 10 milliliters. Calculation/rationale, 20 ml equivalent divided by 2 ml equivalent /ml equals 10 milliliters. Strategy, always compute milli equivalent divided by concentration, milli equivalent per ml equals ml. Question 28. A trauma patient receives massive transfusion and develops hypocalcemia. Why does massive transfusion cause low calcium? A. Citrate in blood products chelates calcium. B. Hemolysis releases potassium, displacing calcium. C. Massive transfusion causes renal loss of calcium. D. Stored blood increases serum phosphorus which lowers calcium. Answer, A. Citrate in blood products chelates calcium. Rationale, citrate anticoagulant binds ionized calcium, with rapid transfusion citrate load can exceed liver metabolism hypocalcemia. Strategy, in rapid transfusion think citrate toxicity low ionized Ca. Question 29, SATA. Which treatments help correct metabolic acidosis due to renal tubular acidosis, type 1? A. Oral bicarbonate replacement. B. Thiazide diuretics. C. Potassium citrate. D. Sodium polystyrene sulfonate, K-exolate. E. Treat underlying cause. Answer, A, C, E. Rationale, alkali replacement, bicarbonate or citrate, and addressing cause are mainstays. Thiazides help in type 2 proximal RTA sometimes. K-exolate treats hyperkalemia not the acidosis directly. Strategy, acidosis from RTA alkali therapy plus K plus management. Question 30. Which electrolyte abnormality is most associated with paresthesias, carpopedal spasm, and perioral numbness? A. Hypermagnesemia. B. Hypocalcemia. C. Hypernatremia. D. Hypokalemia. Answer, B. Hypocalcemia. Rationale, neuromuscular excitability from low calcium produces those classic signs. Strategy, clinical signs of tetany point to low Ca. Question 31, case. A patient with SIAD is receiving demeclocycline. Which lab/assessment finding indicates the drug is beginning to work? A. Increased urine osmolality. B. Decreased serum sodium. C. Increased urine output and rising serum sodium. D. Decreased thirst only. Answer, C. Increased urine output and rising serum sodium. Rationale, demeclocycline induces renal resistance to ADH, causing dilute urine and correction of hyponatremia. Strategy, effective SIADH treatment more urine, rising Na. Question 32, odd one out. Which is not a typical cause of hypermagnesemia? A. Excessive magnesium antacid use in renal failure. B. For magnesium sulfate for preeclampsia in renal impairment. C. Excessive loop diuretic use. D. Adrenal insufficiency with decreased excretion. Answer, C. Excessive loop diuretic use. Rationale, loops cause Mg loss, hypomagnesemia. The others can cause Mg accumulation if excretion impaired. Strategy, loops loss of Mg, renal failure plus Mg load high Mg. Question 33, calculation/priority. You must infuse KCl at 8 ml equivalent/HR via peripheral 4. A 40 ml equivalent bag is started. How many hours will it take to finish the bag? And what is the nurse's max safe peripheral infusion rate for KCl most commonly taught? Answer both, hours, milli equivalent/HR. Answer, 5 hours, max safe peripheral equals 10 milli equivalent/HR, commonly taught, many facilities limit to 10 milli equivalent/HR. Rationale/calculation, 40 milli equivalent divided by 8 milli equivalent/HR equals 5 hours. Peripheral maximum commonly 10 milli equivalent/HR, verify facility policy. Strategy, be able to calculate time and know peripheral safety limits. Question 34. A patient with chronic diarrhea is most at risk for which electrolyte disturbance? A. Hyperkalemia. B. Hypokalemia. C. Hypercalcemia. D. Hypermagnesemia. Answer: B. Hypokalemia. Rationale: GI losses, diarrhea, commonly cause K+ depletion. Strategy: GI losses sodium, potassium, bicarbonate loss depending on stool, diarrhea often hypokalemia plus metabolic acidosis. Question 35, SATA. Which of these drugs can cause hyperkalemia? A. ACE inhibitors. B. Spironolactone. C. Insulin. D. NSAIDs. E. Beta blockers. Answer: A, B, D, E. Rationale: ACE inhibitors and spironolactone reduce K+ excretion. NSAIDs and beta blockers can also raise K+, interfere with renin or shift. Insulin lowers serum K+. Strategy: recognize meds that impair renal K+ excretion or shift K+ out. Question 36, case. A patient with hypervolemic hyponatremia from cirrhosis, which intervention is most appropriate? A. Rapid 4-hypertonic saline. B. Fluid restriction and sodium restriction, treat underlying disease. C. Give hypotonic fluids. D. Increase oral free water intake. Answer: B. Fluid restriction and sodium restriction, treat underlying disease. Rationale: hypervolemic hyponatremia involves excess total body water and sodium. Treatment focuses on fluid/salt restriction and managing underlying cardiac/liver failure. Hypertonic saline would worsen volume overload. Strategy: match treatment to volume status. Hypervolemic equals fluid/sodium restriction. Question 37, fill in the blank. The anion gap is calculated as Na plus minus, Cl minus plus HCO3 minus. An elevated anion gap suggests the presence of acids. Answer: unmeasured, organic, acids e.g., lactic acid, ketoacids. Rationale: high anion gap metabolic acidosis indicates accumulation of acids not measured in routine labs. Strategy: elevated Ag, think lactic acidosis, DKA, renal failure, toxins. Question 38. Which ECG change is an early sign of hypokalemia? A. Peaked T waves. B. Flattened T waves and U waves. C. Shortened PR interval. D. Widened QRS. Answer: B. Flattened T waves and U waves. Rationale: hypokalemia causes flattened/inverted T waves and prominent U waves. Peaked T waves suggest hyperkalemia. Strategy: ECG patterns help distinguish hypo versus hyperkalemia. Question 39, SATA. Which are complications of rapid correction of chronic hyponatremia? A. Central pontine myelinolysis, osmotic demyelination. B. Seizures if left untreated. C. Permanent neurologic deficits. D. Cerebral edema. Answer: A, C. Rationale: rapid correction, osmotic demyelination, central pontine, and potential permanent deficits. Seizures can occur with hyponatremia itself. If untreated, cerebral edema is a risk with acute hyponatremia/water influx rather than rapid correction. Strategy: for chronic hyponatremia, correct slowly to avoid demyelination. Question 40, case/calculation. A patient is ordered 3% NaCl at 30 ml per hour. How many milliequivalent of Na plus are delivered per hour by 3% NaCl? 3% NaCl is almost equal to 513 milliequivalent/L of Na plus. Show the hourly milliequivalent. Answer: approximately 15.4 milliequivalent/HR. Calculation/rationale: 513 milliequivalent/L equals 513 milliequivalent per 1000 milliliters. At 30 milliliters per hour, 513 milliequivalent divided by 1000 milliliters times 30 milliliters equals 15.39 milliequivalent/HR is almost equal to 15.4 milliequivalent/HR. Strategy: Convert concentration per L to per ml, multiply by infusion rate. Question 41. Which acid-base disturbance is most likely to produce compensatory hypoventilation? A. Metabolic acidosis. B. Respiratory alkalosis. C. Metabolic alkalosis. D. Respiratory acidosis. Answer: C. Metabolic alkalosis. Rationale: in metabolic alkalosis, the body hypoventilates to retain CO2 to lower pH back toward normal. Compensation. Strategy: metabolic changes respiratory compensation, opposite direction. Question 42, SATA. Which lab findings are typical of renal failure-associated hyperkalemia? A. Elevated BUN/creatinine. B. Oliguria/anuria. C. Metabolic alkalosis. D. Tall peaked T waves on ECG. E. Hypophosphatemia. Answer: A, B, D. Rationale: renal failure decreased K plus excretion, hyper-K, oliguria, elevated BUN/CR, ECG changes, peaked T waves. Metabolic acidosis, not alkalosis, often accompanies renal failure. Hyperphosphatemia, not hypo, is typical. Strategy: renal failure hyper-K, high phosphate, acidosis. Question 43, calculation/interpretation. ABG, pH 7.25, PaCO 230 mm of mercury, HCO3-13 milliequivalent/L. Interpret this ABG. Answer: primary metabolic acidosis with partial respiratory compensation, acute or chronic depending on context. Rationale: low pH, less than 7.35, with low HCO3 indicates metabolic acidosis, PaCO2 is low, hyperventilation, as compensation. Expected respiratory compensation for metabolic acidosis is hyperventilation, Winter's formula. Strategy: use pH plus HCO3 to identify primary disorder, then check PaCO2 for compensation. Question 44. A patient with pancreatitis is found to have hypocalcemia. What is an expected associated lab change? A. Hyperphosphatemia. B. Hypophosphatemia. C. Elevated albumin. D. Increased PTH activity. Answer: A. Hyperphosphatemia. Rationale: pancreatitis can cause fat saponification with calcium binding and phosphate shifts. Also, hypocalcemia often accompanies hyperphosphatemia, especially renal failure. Strategy: fat necrosis in pancreatitis can lower Ca-phosphate relation varies, check context. Question 45, SATA. Which are true regarding TPN, total parenteral nutrition, and electrolytes? A. TPN initiation may cause hypophosphatemia during refeeding. B. TPN always prevents all electrolyte disturbances. C. Frequent monitoring of glucose and electrolytes is required. D. Magnesium and phosphate must be included/monitored. Answer: A, C, D. Rationale: refeeding syndrome with TPN can precipitate severe hypophosphatemia. Close electrolyte/glucose monitoring required, Mg and phosphate need attention. TPN does not eliminate electrolyte problems. Strategy: TPN patients require daily lab checks at first and attention to phosphate/Mg/K. Question 46, odd one out. Which condition is least likely to cause hypernatremia? A. Diabetes insipidus. B. Excessive hypertonic saline administration. C. Profuse sweating without water replacement. D. SIAD. Answer: D. SIAD. Rationale: SIAD causes hyponatremia, water retention. The others can produce net water loss or sodium gain hypernatremia. Strategy: SIAD equals low Na, DI/excess salt equals high Na. Question 47, case/priority. A patient with severe burns has a high insensible fluid loss and a rising hematocrit. Which is the nurse's most appropriate immediate intervention? A. Start isotonic fluid, 0.9% NS, bolus to restore intravascular volume. B. Restrict fluids and give diuretics. C. Give D5W to replace insensible loss. D. Give PRBCs immediately. Answer: A. Start isotonic fluid bolus to restore intravascular volume. Rationale: burns cause capillary leak and intravascular hypovolemia. Isotonic crystalloids restore intravascular volume. Diuretics would worsen hypovolemia. PRBCs only once stabilized and indicated. Strategy: in burns think large volume isotonic resuscitation early. Question 48, SATA. Which signs are associated with hypercalcemia? A. Constipation. B. Bone pain. C. Polyuria/polydipsia. D. Hyporeflexia. E. Muscle cramping/tetany. Answer: A, B, C, D. Rationale: hypercalcemia causes constipation, bone pain, if from bone resorption, polyuria/polydipsia, nephrogenic DI, and decreased reflexes. Muscle cramping/tetany is more hypocalcemia. Strategy: hyper-Ca stones, bones, groans, thrones, psychiatric overtones, mnemonic. Question 49, calculation. A bag of 0.9% NS contains 154 milliequivalent/L of Na+. A patient is getting NS at 125 milliliters per hour. How many milliequivalent of Na+ per hour is the patient receiving? Round to 1 decimal place. Answer: 19.3 milliequivalent/HR. Calculation/rationale: 154 milliequivalent/L equals 154 milliequivalent per 1000 milliliters. At 125 milliliters per hour open parenthesis 154 divided by 1000 close parenthesis times 125 is equal to 19.25 19.3 milliequivalent/HR. Strategy: convert per L to per ml then multiply by ml/HR. Question 50, final tricky synthesis. A patient admitted with acute dehydration has Na 150 milliequivalent/L, K 3.1 milliequivalent/L, BUN/CR ratio elevated, and urine osmolality high. The physician orders 0.45% NS at maintenance. The nurse is concerned because A. Hypotonic fluid may worsen hypernatremia and cause cellular swelling. B. Hypotonic fluid will correct hypernatremia safely in acute dehydration. C. Isotonic fluid would be preferable initially to restore intravascular volume before hypotonic replacement. D. Both A and C are correct. Answer: D. Both A and C are correct. Rationale: with hypernatremia and signs of hypovolemia, isotonic fluids, 0.9% NS, are preferred initially to restore intravascular volume. Hypotonic fluids can shift water into cells and are used later and cautiously to correct hypernatremia. Starting 0.45% NS may worsen intravascular depletion. Strategy: always treat volume status first, restore circulation with isotonic fluid and electrolyte questions. Sodium gradually. You've tackled prioritization, lab interpretation, calculation, and scenario-based critical thinking, the exact skills you need to pass the NCLEX with confidence. Remember, it's not about memorizing numbers, it's about understanding what those numbers mean for your patient and acting fast to keep them safe. Keep practicing these questions until the answers feel second nature, and you'll walk into the exam ready to dominate. You've got this.